Welcome back. We're going to switch gears a bit here and check in with a most unfortunate patient. By the end of this, you should be able to list the common elbow-related fractures that can occur, identify nerves that could be injured with specific fractures, and describe the static and dynamic stabilizers of the elbow joint. If it's been a few days, rewatching the podcast about x-rays of the elbow will help you here. So, Carol, it's January and she's been looking forward to a quick run to Palm Springs for a bit of sun. But she's late and she's running along the airport concourse. She then trips over a pile of luggage and lands onto her left arm. It's immediately clear that something is wrong and she is not getting to Palm Springs today. So thinking about what's in the mid-arm, what are possible injuries she could have sustained? So this is the summary list of things that we may encounter here. These injuries all involve a dislocation of an elbow articulation. While these tend to knock out important soft tissue stabilizers as well as bony structures. So, humeral shaft fractures are uncommon, but the classic association is an injury to the radial nerve as it hugs the bone. These may be treated with a cast brace or with internal fixation. It's still controversial which may be ultimately superior, although the randomized controlled trial running in Canada has been languishing for years because of the low incidence of this fracture. Distal humerus fractures are a little bit more common. The nerve at risk here is the ulnar nerve, because it's very close to the bone at the level of the fracture. These may be into the joint surfaces or just above the joint and can range from 2 pieces to thousands. Almost all of these go on to surgery. On the left is a typical array of internal fixation for a distal humerus fracture. You can see they've emptied the toolbox. On the right, an elbow replacement. These are some of the most difficult fractures to treat for orthopedic surgeons and may result in permanent loss of function or life-changing disability. Radial head fractures, on the other hand, are as common as dirt by comparison to the first two. Fortunately, most of the ones we see are only mildly displaced without any complicating factors. The important thing to note here is that sometimes, especially with the really smashed up ones, the ligaments that bind the radius and ulna together, called the interosseous membrane, can be torn all the way to the wrist, and this destabilizes the entire forearm complex. So pay attention to the wrist when you look at the elbow. These are a few example x-rays on the left here. Almost all of these can be treated with a sling, a few need internal fixation, and a few get replaced. It's common to lose a little bit of elbow extension, even with minimally displaced fractures. But unlike the other actors on this list, these do tend to be pretty benign most of the time. Olecranon fractures are also fairly common, and they're a problem because it involves the elbow joint surface and because the triceps muscle pulls the fractured piece away from its normal position. Almost all of these get surgical fixation. So let's talk about stability. The elbow is defended a little bit like a medieval castle. There's walls, and lots of walls. As with the shoulder, there are static and dynamic stabilizers. Unlike the shoulder, the bony shape of the elbow plays a much greater role in static stability. Two ligament groups, the lateral or radial and the medial or ulnar, also contribute significantly. There is relatively less contribution by dynamic stabilizers, but they're still important. As before, static stabilizers that become deficient will often require reconstruction. So now that we know this, let's look at elbow dislocations. And by elbow, we typically mean the ulnohumeral articulation. These are sort of classed as simple or as terrible triad. The x-ray on the top left shows a common type of simple dislocation. You can see the humerus has jumped over the coronoid process of the ulna. Lower down, we have a similar situation, except you can see that the humerus has exited by smashing through the coronoid process and the radial head. One of these is going to be fine with rehab, and the other is going to need some skilled surgery. So this lower film shows us something that we tend to call the terrible triad, which is a combination of radial head fracture, coronoid tip fracture, and disruption of the medial / ulnar collateral ligament. We call it the terrible triad because historically this has led to real trouble in the elbow. The first step for both of these is going to be to put the elbow back in joint. In adults, the most common elbow-related dislocation is the ulnohumeral joint that we just looked at. However, the other classic is a radial head dislocation, and this is much more common in kids. This film up top shows the radial head very much not pointing at the capitellum. When you see that, you have to take pictures of the entire forearm and wrist because you may miss the accompanying ulnar fracture required to get this. The key here is to recognize this injury, as it's not always this clear, and missing it can lead to a lifetime disability that begins in childhood. At the emergency department, Carol's arm is swollen around the elbow and doesn't look right. She's got intact nerves and blood flow, but her pinky finger is tingly. We've seen these pictures before back in the podcast on radiographs. This is an elbow dislocation with fracture, or for our purposes, a terrible triad type injury. Her treating physician elected to get a CT scan before placing the elbow back in joint, which is a debatable order of operations, but it does afford us this really nice set of 3D reconstructions that really demonstrates how this humerus bulldozed its way out of the joint. On the left, we see that coronoid fragment, and on the right, we really see how the radial head has been blown apart and displaced. So the next steps is we want to get that elbow back in joint and splint it at close to 90 degrees of flexion for enhanced stability. And if we haven't got the CT scan already, this is the time to do it. Once things are back in joint, Carol is referred immediately to an upper extremity orthopedic specialist for definitive treatment. The surgeon replaces her radial head and repairs the coronoid fracture. In the end, she does okay, but the elbow's a bit stiff and doesn't really like a lot of heavy activity. So by way of summary, elbow fractures and dislocations often require orthopedic management and surgery, and stiffness really is the enemy, which is why treatment aims for early mobilization. There's often a mixture of bony and ligament injuries, and you really want to get good x-rays so you can actually see what's going on. So to review, we've seen the common and the classical examples of elbow trauma. We've looked at some nerves that can get injured, and we've talked about static and dynamic stabilizers of the elbow joint.